today we have a very interesting person to talk to. He's been working as an ophthalmologist for the last 22 years and has previously worked at St. Thomas's Hospital, King's College Hospital and the Royal Free in London. He now works as a consultant at the Moorfields Eye Hospital and in Harley Street and has been doing so for the last 11 years. He specializes in cataract surgery and treating retinal diseases. This is Jaheed Khan. Thank you very much for joining me today.
Hi, Bansi. Thank you very much for inviting me.
So I wanted to ask you, what's the most difficult patient or pathology that you've had to deal with?
I think on the whole, it's the younger patients that have lost vision quite rapidly, say due to very high risk proliferative diabetic retinopathy, who have remained uncontrolled for a long time, who present very late. Those are the hardest ones to deal with because you've kind of missed the opportunity to treat them as a preventative rather than catching them right at the end stage of their disease, and they rapidly deteriorate if they're not treated. They're the really challenging type of patients.
And when so if you see a pathology that would indicate your patient's at risk of a sight-threatening or even life-threatening condition, how would you deal with the discussion with the patient and even your emotions thereafter?
Well, I think it can be quite challenging to remain objective and trying to remain empathic towards patients who obviously have very bad news on occasion. But as doctors, I think we develop a certain level of resilience and look at things objectively and try to remain positive and try to offer the best treatments we can to do that. But yes, you're absolutely right. It can be very heartbreaking when people don't respond to treatment and lose vision.
And from an optometrist point of view, what sort of pieces of advice would you want us to discuss with our patients before we refer them to you?
I think obviously have a frank discussion with your patients as to what your concerns are. If you're unsure of a diagnosis, obviously don't launch yourself into a certain diagnosis that obviously has ramifications, and patients will start to look it up on Google and say, look, I think this needs a referral, a second look. If you're unsure, then keep it fairly open, try and remain positive and encourage patients not to worry.
And what sort of advice have you got for optometrists that want to work in that hospital sort of environment?
I think it's a great experience to want to work in a hospital environment, especially if you have that balance between hospitals and communities. And there's been an increasing need for community optometrists to work in hospital environments to provide the increasing workloads that we have, that have continued through the pandemic and were an issue before then. My advice is, contact your local hospital, talk to the HR departments, talk to people you know at the departments, talk to colleagues who've already worked there, see what their routes have been, and try and get as much experience, try and do IP courses, modules, that, retinal or glaucoma modules that are offered, and try and build up your CV so you're as attractive as possible to those sort of positions.
So how easy would you say it is to get a placement in the hospital environment? Are you seeing lots of optometrists in your hospitals?
Yeah, we have quite a lot of optometry allied health professionals who do provide a lot of the extra capacity that we need to treat the numbers that we're seeing. How easy? It's getting a little bit easier, but as I say, it's quite competitive because people want to do it. But I'm sure, with persistence and with the right routes, you'll find a niche, and the roles are expanding in general hospitals as well, not just at Moorfields. We're getting nurses to do more injections. Optometrists are doing much more virtual clinics and glaucoma medical retina clinics. So there's definitely a need.
So with legal cases that I'm sure you're aware of, like with Honey Rose, there's an element of sometimes maybe we don't have the confidence we need. So what sort of advice would you have to give to community optometrists to gain the confidence they need to make appropriate and confident referrals?
I think it's hard. It's very hard if you're a community optometrist and you're on your own, because we're lucky in a hospital environment. We have people to ask and ideas to bounce off. But I would suggest that you keep up to date, make sure that your CPD is up to date, make sure you keep learning, make sure that you're aware of the latest treatments and all the evidence-based studies and things like that, which are all part of good clinical practice on the whole. Be part of a network, join WhatsApp group. I have a WhatsApp group that people can bounce ideas off, ask queries, ask questions, be involved and just keep learning.
And I have a couple of students that have sent through some questions that they wanted you to answer. So based on a cataract referral, what would you say is an acceptable reduction in vision before we can refer to your patients? Is there a difference between NHS and private patients?
There is, unfortunately. On the NHS, we have to ration who gets cataract surgery. It's a function of the fact that we have a limited pot of money for those sort of operations. The general cutoff is a distance visual acuity, a Snellen vision acuity of 612 or worse in the worst eye. That obviously is debatable because the quality of vision can be far worse if people have 6/6 vision and their driving ability is affected. From a private healthcare point of view, we operate on cataracts when they become symptomatic. So the visual acuity becomes secondary in terms of what people can measure on a chart, because as you know, the ability to see is based much more on, you know, what we see in the real world and what our visual dysfunction is. So on the NHS, yes, you do have to refer at 612 or worse level. In private healthcare, when the cataract's particularly symptomatic.
So I had an interesting patient actually on Tuesday who was really struggling with her glasses, and it came down to the fact that she's had one cataract done, hasn't been put onto the list for the other eye because the vision in that eye is still 6/9, I believe. And where she's got or plano prescription in her eye that she's had the cataract surgery, she's now been left largely anisometropic. So in that sort of situation, although the vision might be okay, would you still accept a referral because they're having difficulty or non-tolerance to their prescription?
Yeah, absolutely. That's one of the valid indications for second eye surgery is significant anisometropia. We recognise that is debilitating for patients, especially if they have a difficulty fusing the eyes because of prescription. So don't worry, refer in, that will be done based on that criteria.
And on a slightly different aspect, if the patient had amblyopia, so you know that their vision's poor anyway, would it still be suitable to refer that kind of patient or not so much?
Well, that's a difficult question depending on the amount of or the degree of amblyopia, I should say. So let's say you've got a very densely amblyopic eye and there's a mild degree of cataract. It may not be indicated in that respect that the cataract operation is going to be significantly beneficial. But if you've got mild amblyopia, as some patients do, and you've got a significant cataract, you probably would benefit from doing surgery in those instances, because you're not going to try and get them to 20/20, but you're trying to get them to the best possible vision that they've had before the cataract developed. So it does largely depend on the degree of amblyopia and the degree of cataract.
And one of the other things or conversations that we have with our patients is how safe they are to drive. So obviously, we don't say to them that you are or are not allowed to drive, but we might recommend that maybe it might be worth waiting until you have that surgery done. So after you see that patient and they do their cataract surgery, how long would you say the patient has to wait before they can drive again?
Well, that all depends on, in terms of how they adapt to their new prescription. Someone who's very short-sighted, who's been made ametropic, may take up to 5 to 7 days to adjust to their new prescription. But on the whole, most of my patients can drive after a week. It's pretty much safe to do so, and they probably adapted from a neural point of view fairly quickly.
And a slightly different question, actually, that one of the students has sent across is with regards to lens choices for the IOL. Is there a multifocal lens that we can recommend under the NHS referral?
At this stage, there isn't a routine, there is no routine financing for multifocal options. Yeah, at Moorfields, sometimes we do multifocal studies where you're recruited. But again, not strictly through the NHS as such. That option, unfortunately, is only available through private healthcare because, again, the CCGs that fund the service don't think it's particularly cost effective to provide that.
And on a different note, we've been talking about cataracts, but if we look at, for example, on the retinal layer, if you have a referral for a pigmented lesion, would you refer it just because it's not been previously noted, or what sort of things do I need to look out for before I refer them to you?
Sure, pigmented lesions can be a bit of a minefield for sort of junior optometrists, partly because you're obviously very concerned about missing a malignant melanoma, a choroidal melanoma particularly. Thankfully, that's rare. But if you do see a pigmented lesion and you're confident that you can identify the malignant features or absence of malignant features, then you can continue monitoring in practice. If you're unsure or you feel that this is a new lesion that you've not been documented before, I would suggest taking a photograph as a baseline investigation. And if you feel there are any particular suspicious features, refer in, we will take a photograph, we will document that the lesion is benign, and then it can be referred back to the community. I think the issue is when you start holding on to them in the community and no one's really sure of whether it's new and whether it's changing. I think a referral is warranted then in that instance, I think.
And a personal sort of question, have you ever had any situations where your patients that you've instilled drugs into, so any kind of cycloplegics or mydriatics, have your patients had any side effects or any adverse reactions, and what did you do in that situation?
I think, thankfully, topical drops have very good side effect profiles, and they don't tend to cause immediate or allergic reactions in clinic. Sometimes people get allergic reactions later down the line, maybe some slight itch, but acute allergy is pretty unusual. We see that more when we instill intravenous fluorescein for fluorescein angiography. And that's when you have to be very careful, because then a certain percentage of patients can be allergic to the dye. But on the whole, topical administration of drops is pretty safe. Some of the glaucoma drops have preservatives and side effect profiles which make people irritated in the long term. That's slightly different.
Okay, thank you very much. We've managed to get through all the questions that we have time for just now, and hopefully we'll be seeing you again in another interview sometime soon.
I'd love to. Thank you, Pansy.